So look, the next two talks are really combined. So I'm actually not going to talk for very long at all because Ione, who works with me doing a PhD at the moment, is the person that's doing all the work on this. So I'm going to let her talk really about most of it. But it leads a bit on from what Matt was talking about, which is, look, how do we try and understand this disease a bit better? And we're going to talk today about how we're trying to understand it through blood tests and through spinal fluid measures. And of course, in an ideal world, and we all talk about how difficult it is to get a diagnosis. Wouldn't it be easy if we had a blood test? You could go to your GP and there was a blood test for FTD, and we don't have that at the moment. And so we're going to talk a little bit about some of that kind of work that we're doing here at the National Hospital for Neurology, and about why actually blood may well be the end answer, but actually using spinal fluid measures are really helpful, and why the way we get that is through lumbar punctures. So a bit about what are the sort of unanswered questions, why FTD is a challenge, and I'll go over some of the things that Matt's already really gone over. And then we'll talk a bit about what a lumbar puncture is, how we use it in general, and how we're trying to understand FTD through these different measures. So at the moment, as Matt said, look, we know a bit about dementias and we know about the symptoms. We're better at diagnosing it. We definitely know more about these pathways. But actually, what we don't have is an exact answer on why me? Why do I have this dementia? Why has somebody developed this? We don't know the answer to that. And we want to know that because actually that will help us develop treatments. So particularly in FTD, as I'll show, there are obviously lots of different types and different causes, and at the moment it's hard to know what the underlying protein is in a specific person in life. So we talk about these different proteins like tau and TDP in people with FTD, but actually during life it's very hard to work out who has which type of protein accumulating in their brain. And of course, you know, we talk about why do we try and diagnose this early? I think there are multiple reasons to get an early diagnosis. Information is key, and you know, I think, yes, at the moment we don't have any treatments, but the knowledge of what the diagnosis actually is, rather than living in ignorance for a number of years and waiting for a very long time to get a diagnosis, is a very difficult situation to be in, and we do our best to work out how we can improve that diagnosis. And in the long term, making that diagnosis as early as possible is clearly going to be helpful in trying to treat that disease as early as we can. So lastly, a bit to the question that we've just been hearing about. How do we know how quickly the disease is going to go? And as Matt just said, that's a question we all get asked, is how long is this disease going to last for, and how quickly is it going to go down? And again, we don't know the answer to that. That's a very difficult question, and as Matt said, you know, the longer you see someone for, the easier sometimes it is to predict, is this disease going quickly, is it going slowly? But at the moment, we don't have a sense of being able to predict that. So these are all things that we'd like to do, and like to do with some form of test. But the challenge of studying FTD, Matt's really just told you. So I tend to use this term FTD to mean all the syndromes, and we talked about the fact there are lots of different clinical syndromes. So the behavioural variants, these primary progressive aphasia illnesses, so the non-fluent aphasia and semantic dementia, and then this overlap with both motor neuron disease, but also these Parkinsonian syndromes, which are called PSP and corticobasal syndrome. And as we said, there are lots of different proteins accumulating. So there's the tau protein, and then there's this group of other proteins, all got funny names, TDP, FUS, and this other smaller group at the end. And these are the proteins that Matt was talking about that are accumulating in the brain. And then there are these genetic types that Matt talked about as well. So people who have mutations in the tau gene and progranulin gene, and this other gene with a very long name, C9orf72. And those are the most common genes, but actually the more time goes on, the more we recognise there are some less common genes. This is a mess. This is what we're trying to deal with. So when we talk about FTD and we all come here and we sit and we talk about this as one disease, it's just not one disease. Each one has a variable presentation. So you might just have behavioural symptoms, but you might have behavioural symptoms and language symptoms and have developed motor neuron disease. And that isn't that helpful in telling us which of these different proteins in the middle that is going on in the brain, what's actually accumulating in the brain. And then there are all these different genes at the side. And solving this complex picture is what is going to help us cure the disease, because it is likely that there are going to be treatments that are directed specifically against the individual proteins or for particular genes. Oh. You might have to take over. Sorry, talking for too long. This is an even more complex version of that picture with all different subtypes. So, the basic thing is we need some markers to try and help us to work out what's going on. That is a good time to hand over to Ione before I cannot talk anymore.
Just going to move this down. So, moving forward from there, we've talked a little bit about how we predict when disease is starting, or perhaps what things are happening in the brain, right from when the proteins start to build up in these nerve cells, through into detecting these through various blood tests and brain scans. And we know from some studies so far, such as the genetic FTD study that John Rohrer heads up, that there's a series of ordered changes that we can detect over time. So if we go back in time, starting with people who have symptoms of FTD, we know it affects their daily life, we know it affects their function. And that's due to changes in behaviour as well as language and other social and emotional processing. And those particular behavioural changes and difficulties with language and memory and other things that could be affected are picked up on psychology tests, which we do to diagnose the type of dementia and also as part of our research. However, we can also, in some cases, see changes such as the brain shrinkage over time on structural scans looking at the brain. MRI scans are the most sensitive ones we have at the moment. But there are also other scans that we know look at the function of the brain. So not just the PET scans that Joan's talked about, but also others looking at the connections between different parts of the brain and whether those are broken down. PET scans are on there as well, and they show how active or underactive different parts of the brain are. But what I'm really interested in, and what we think might be some of the earliest markers, are changes in the blood and in the spinal fluid, and that's the fluid that surrounds the brain and the spinal cord. And the idea is to try and do research into picking up markers of those that you can test over time, either through a blood test or a spinal fluid lumbar puncture, to detect that in patients and individuals at risk of developing FTD, particularly people, for example, who might carry a gene but not yet have symptoms, so people within families of people with FTD, so people my age or older than that or younger than me who might know that they are at risk and want to know when things are changing. So this is what we're interested in. I'm going to talk a bit about that. And some people here, and perhaps relatives and patients, are a part of our 2 studies into FTD here at UCL. The GenFI is the genetic FTD, looking at people with those 3 mutations that we've mentioned, MAPT, progranulin, and C9orf72. And LIFTED stands for longitudinal investigation into frontotemporal dementia, and that's looking at people without those known genes, so sporadic FTD, people we don't know the cause of. And people come to our centre over the road, the Dementia Research Centre, once a year, usually for a day or 2, and they have an MRI brain scan, some psychology tests, a clinical assessment with a doctor such as myself or my colleague, Charlie Marshall. Some of you might have met him. And some people are having a PET scan at the moment, not everyone. We also take pictures of the back of the eye because there's a theory that, like if you go to the optician and have a picture of your retina, that's obviously a clinical test, but on a research basis, we're trying to see, can there be changes in the nerve cells that are part of the retina that we can reflect what's going back on in the brain? So a kind of less invasive test. And finally, a blood test and also a lumbar puncture to collect various bodily fluids that we can do research into. I don't know if anyone was here at the support group last year. I talked a bit about what a lumbar puncture is, but we do lumbar punctures a lot in patients with different types of dementia as well as part of our research. And there's a lot of bad ideas about lumbar puncture around, particularly on the internet. If you look it up, it's probably not a good idea to look into forums and things. So I thought what I'd do today is just talk you through what actually is a lumbar puncture, why we do it, and what kind of research is coming out from those tests as part of our research into FTD. Often people will come with their relative to have the lumbar puncture, and it's useful to have some informational tips before the day just so you're less anxious about it. And we obviously provide these, but some people say this is helpful to know what's going to happen beforehand. So the spinal fluid is produced by certain cells within the depths of the brain, in the ventricles, the spaces of the brain. And all the time the brain is producing small amounts of fluid that bathes the brain in the spinal cord. It nourishes it, we think it cleanses it, but also as nerve cells perish, they release various proteins into it. And this is really why we're interested in detecting this. And the way we access this fluid is not through up near the brain, because obviously that's potentially dangerous, but in the lower back where the spinal fluid collects in a pool just below where the spinal cord finishes. Now, the reason it's called a lumbar puncture is that's in the lumbar region of the back, and that's how we access it, through a needle going through between the little vertebrae, the backbones, into that space. So what kind of things can looking at the spinal fluid tell us? Well, obviously, in this particular category, we're interested in loss of brain cells or perishment of brain cells over time, and that's known as dementia. That's a global term for loss of brain cells over time. But also in other people with different other conditions, we use the spinal fluid, for example, looking at whether someone has a serious infection in the brain. For example, someone comes in acutely unwell to the hospital with a fever and headache and things, and we can look for meningitis. We talked about multiple sclerosis, which is a different condition affecting the brain. We can look for that. And if someone has, for example, a concern about a sudden bleed in the brain, we can use the fluid to analyse that, as well as other changes in the fluid pressure. Not in frontotemporal dementia, but in other conditions where the fluid is a problem, we can either remove fluid for treatment, or perhaps if someone has brain cancer, or cancer spreading into the brain from other conditions, we can give chemotherapy or treatment for that into the fluid. So the fluid is very useful to us, not only for diagnosis, but also for treatment. So the next bit of the talk is just going to quickly go through how we do the lumbar puncture. Can I ask, has anyone here had a relative or themselves had a lumbar puncture? Okay. So some of you will know what's involved, but for those of you who don't, I thought I'd just go over it, and perhaps it's useful to know this for anyone else you know who's going through this. So the way we do the lumbar puncture is we need to get between those spaces in the spinal column, so the vertebral spaces. And the best way to do that is to either lie people on their side and bring their knees right up to their chest, they're curled into a little ball, and that opens up the spaces. Or perhaps to sit people forward, leaning forward. It depends on the person doing the procedure. And those two positions are shown here. People don't have to kind of not eat or drink. It's not like an operation. You just turn up on the day and have the procedure, and it takes about an hour. The first thing the doctor will do will feel down the spine, because we need to go below where the spinal cord finishes. So if you feel your hips, that's what we call L4, lumbar 4, and we either go just above or just below that level in the spine. It's important that we don't introduce any bacteria or viruses or anything into the fluid, because normally there isn't anything like that in there. It's a very clean area, so we're very careful to clean the skin, wear kind of gloves, and make sure that's not going to happen. We also give people an injection of local anaesthetic to numb the skin, which can help make the actual lumbar puncture less painful. The lumbar puncture needle everyone is terrified about, but actually it's a very thin needle. It's quite long because it has to go through the skin, and some people have more fatty tissue than others, and also various ligaments. But really it's a very small needle, and once the local anaesthetic is in, it's not really painful, you just feel the pushing of the needle. Once we know we're in the space, and we know we're in because we can feel a little give as we get into the space, the fluid is just left to drip out into a little pot. I was asked last year whether we ever suck the fluid out. We don't do that because that would potentially cause a pressure change that could be dangerous, so we just let the fluid drip out, and people have different rates of fluid drippage. That takes a bit of time. We then take the needle out, and we put a little plaster or dressing on. And then people, we recommend that they rest for an hour afterwards, lying flat. The reason for that, and I'll talk about this in the next bit, is due to some of the minor side effects of the procedure, which obviously everyone is interested to know about. So just before I talk about side effects, I'll just recap. So it's all about position, either lying or sitting, feeling the spine for the right space, making sure everything's clean. We put some local anaesthetic in, we insert the needle, collect the spinal fluid, remove the needle and put a dressing on, and people rest afterwards. Any questions about that at all at this stage? Yes?
What about people who cannot lie flat because of their breathing?
We then sit them up. So those people who have difficulty with breathlessness on lying flat, we would sit them up over the edge of the bed with a box underneath their feet and lean them forward. So yeah, we accommodate, some people are less flexible due to arthritis or pain, and so we accommodate that according to the position that's best for them.
Even if they rest afterwards?
Yeah, so ideally people would rest flat. We do have sometimes people rest at 45 degrees, sometimes people sit in a chair, but ideally it would be as flat as possible. But if that's not possible, that's uncomfortable with the person, we're not going to make them do that.
How still does the person have to stay for that hour when it's dripping out?
As still as they can. We understand that for some people that's difficult, and sometimes when someone's become quite agitated or they're confused about what's going on, we have to abandon the procedure because of the risk to them. So we always weigh up the benefits of doing the procedure for diagnosis or treatment versus the risk to that. But actually the risk of damaging things is quite low. It's going to put, we're way below where the spinal cord ends.
The dripping out is, the actual being still is a short, that's not
Yeah.
an hour.
No.
That's 5-10 minutes.
Yeah, so it depends. So it depends on how much fluid you collect. If it's just for diagnosis, we collect a very small amount and it's 5-10 minutes. If it's more for research, perhaps we want slightly more, then we collect maybe 20 minutes. But the actual procedure takes half an hour at the most. Okay, so everyone wants to know, there'll be some time for questions at the end, but I'll move on to some of the side effects. So actually it's a very safe procedure. We wouldn't do it unless it was a safe procedure, and we do them all the time here at this hospital and across obviously the UK. Most people get a little bit of backache, but actually about 1 in 10, so 10% of people could get a post-lumbar puncture headache. And that doesn't usually start straight away. It starts maybe later the day or the day after or the day after that. And usually it goes away by itself in a couple of days, but very occasionally it lasts longer, and that's rare. But basically the reason we think people get the headache is that normally when you take the needle out, everything just closes over within the space. But we think in some people, for some reason, it takes a little bit longer for that hole to seal off, and therefore the pressure takes longer to go back up to normal. So every time someone stands up, the pressure in their system drops and they get a headache, whereas when they then lie flat again, the pressure goes higher and the headache goes away. So the first thing we advise people to do is if they start to get a headache, is just to lie as flat as they can for as long as they can, and then we would call them every day until the headache has improved. It's much better if people try and maintain the fluid, to try and maintain the pressure in the system, and also caffeine can help, so tea and coffee and sometimes Coca-Cola. I talked a little bit about backache. That's just because you've had a needle through the skin or the back, and obviously that's going to cause a little bit of discomfort, but that goes away by itself, and normal painkillers like paracetamol or ibuprofen can help. The ones everyone is worried about, infection, bleeding, things like that, are extremely rare, and I'm talking less than 1 in 1,000 if performed correctly, as we do at the centre, so actually it's a very safe procedure. Some things I always advise people if we're booking people in to have a lumbar puncture is the first thing to know what medications someone is on. So if someone is on a blood thinner, so aspirin, 75 milligrams once a day is okay. But anything more heavy duty like warfarin, clopidogrel, rivaroxaban, these are all names of blood thinners, we would ideally not do the procedure because the risk of bleeding is just that little bit higher with those medications. We would ask people to often bring a friend or relative with you just to chat to someone during the lumbar puncture so it's less boring, but also just to make sure they feel okay going home. It's important to stay hydrated before and afterwards because we think that reduces the risk of lumbar puncture headache. I'm not sure there's a massive amount of evidence for that, but theoretically it could reduce the risk. And I've talked about resting afterwards. Most people don't want to overdo it afterwards, but we've had a couple of people who've gone to the gym or done barn dances or something. Not a good idea, just because it slightly increases the risk of that hole opening up again and therefore the headache starting. So we would say you can walk around, you can rest at home. Most people take an opportunity to kind of be off home duties, which they like, but it's important just to rest. Any questions about that now? Or, yeah.
I would like to ask the patients that's already on lumbar puncture, is it painful? Because I've heard that it is, and I don't know whether that's an old wives' tale or...
Yeah. Actually, the worst bit of the procedure is when we first inject the local anaesthetic. That's just like having a blood test because you've got no anaesthetic in there and then you feel the prick of the needle. It stings a bit. It's not as bad as going to the dentist and having a dental injection, I'm told, but it does sting a bit in the back. Once the anaesthetic works, it takes literally a minute to kick in, then it's not really that painful at all. You might feel a little bit of the needle, but you don't feel pain all the way through the tissues because the local anaesthetic prevents that.
So the needles are finer than what they used here.
They are much... So lots of people who had lumbar punctures as a child, for example, when they were unwell, the lumbar puncture needles were much thicker then, and things have definitely improved since then. Any other questions? Yeah.
I have an FTD diagnosis.
Yeah.
And also have TIA as well, fairly recently. I'm not 100% convinced of the FTD diagnosis, but that's maybe me. But I would be very interested in getting a lumbar puncture. But I'm currently on
Clopidogrel, yeah.
That's the one. That's the one.
So we do,
Is
yeah.
there anything can be done about that?
Yes, so if we really feel that that person needs to have a lumbar puncture to clarify the diagnosis, and I'll talk a bit about how we clarify the diagnosis, if it indicated strongly, we would stop the clopidogrel for 7 days before the procedure. But if they've had a very recent stroke or a TIA, we would think that the risk of that is high, so it would need to be discussed with the person's stroke doctor before we do that. So it's a risk versus benefit. I'm just going to move on now to why actually the spinal fluid is helpful for diagnosing dementia, because most of the research and the progress in this has been in Alzheimer's disease, and in FTD we are slightly behind times in terms of finding a marker for that. So I'm sure people have discussed this before. Just to recap, dementia itself is an overall umbrella term for a condition leading to progressive brain cell loss over time, and therefore changes in thinking, memory or behaviour or any aspect of that. So lots of people ask me, well, what's the difference between Alzheimer's disease and dementia? Well, Alzheimer's disease is one type of dementia. Frontotemporal dementia is another. And there are lots of other types, as shown here. So vascular dementia, dementia with Lewy bodies, and they overlap with other things such as Parkinson's disease and some other Parkinson's-like things. But this is what we're here to talk about today, so I'm going to focus a little bit more on that. And the way we diagnose dementia, I'm sure many of you have been through our clinic or clinics elsewhere, is really based on the history of what has been happening to that person over time, and both their and their family's description of their symptoms. So what things have been happening, what things they've been saying, their behaviour, their language problems. The next thing we would organise is a detailed neuropsychology assessment. That includes lots of different tests of different parts of thinking. So the one here lasts about 2 to 2.5 hours. It's very detailed. It gives us an idea of, well, is it the frontal lobe parts of thinking that are down? Is it the memory parts? Is it the vision? And that gives us a pattern of things that can help aid understanding of what parts of the brain are not working as well as they should. We've talked about MRI scans. If people can't have an MRI scan, for example, they've got metal in them, the main problem is things like pacemakers, which have metal. We can do a CT scan, which is a different type of scan that doesn't use magnets. It's less detailed, but we'll do one if we need to. And then obviously I've talked about having a lumbar puncture, and I'll talk about now about why that particularly is useful. The first thing we want to do, particularly if someone has had a rapid onset of symptoms, is to exclude what's called a non-neurodegenerative cause. So something that's treatable, that's something that's inflammatory, or perhaps a tumour or something like that. So obviously if you do a scan, You want to make sure there's no strokes or tumours or other things that be causing frontal lobe symptoms. So that's the first thing. And what we look at in the fluid is a number of different things. We look at whether there are any white or red blood cells in the fluid. Normally, there shouldn't be any of either of those. It's a very pristine fluid. It's a kind of clear water. It's almost clearer than Evian water. It's really colourless. We look at protein levels. And when I say protein, I don't mean the different types of proteins that have been mentioned before, because at the moment we don't, unfortunately, have very good markers of those, but generally a albumin type protein, and that can go up or down in different conditions. We look at the sugar levels in the fluid, and we look at if there are any bacteria or viruses or other cells that shouldn't be there in the fluid. So that's the first thing. And then we look at dementia markers. So particularly one would want to do a lumbar puncture, for example, if the diagnosis were uncertain, or if someone thinks, well, this could be Alzheimer's disease rather than frontotemporal dementia. But particularly if people are presenting in a young age, and by young, the definition in the guidelines is under 65 years, the guidelines are that people should be having a lumbar puncture really to help separate it out from other types of dementia or other problems. I'm going to talk about two markers that we use in Alzheimer's disease, and that has come through years of research into these proteins that build up in the brain cells and therefore how we can detect them. And those proteins are called amyloid, and I'll show you on the slide after this what amyloid is, and also tau and phospho-tau. So Alzheimer's disease is a different cause of dementia, and it's due to different proteins than frontotemporal dementia. So on the left hand of this image, you can see nice healthy purple neurons or brain cells. In Alzheimer's disease, two things happen, well, multiple things happen, but the two main things are something called amyloid that normally is present in the brain starts to become sticky and clump into what's called plaques or collections of amyloid outside the brain cells. Secondly, tau, which becomes very tangled up, clumps inside the brain cells, and that causes, both of those things cause the nerve cells not to communicate with each other properly and to perish early. This is a microscope picture of someone who's donated their brain after they've died of Alzheimer's disease, and looking down the microscope at the brain cells, we can see the very dark brown amyloid plaque on the left, and in the top right we can see a nerve cell completely full of the tau, which is also brown in colour, using a particular stain that we can look on the brain tissue. And the reason this is important is that through research we've been able to develop a test for spinal fluid to look for changes in those two proteins. So in Alzheimer's disease, in the spinal fluid, you'd think, well, the amyloid might be high because there's lots of it around, but actually, because it clumps in the brain, it doesn't float into the spinal fluid, and therefore the levels are lower, the amyloid levels are lower in Alzheimer's disease. Tau is a marker of brain cell loss, and that goes up as well as another form of tau called phospho-tau, and that's due to neuronal loss over time. So in Alzheimer's disease, if patients have suspected Alzheimer's, we look for those proteins in the fluid. So that's why we use the lumbar puncture, to see whether is this Alzheimer's disease or is it something else. And at the moment, that's the best we've got. So we've got a test for Alzheimer's disease, but we haven't got a similar protein that we can measure for frontotemporal dementia, and that's really why we're doing research into it. This is the same for other types of dementia that overlap, so we don't have a specific protein that we can measure for dementia with Lewy bodies or vascular dementia, and that's what we want to look into. So the final part of the talk, I'm just going to talk about some research that's been done into spinal fluid measures of FTD. And you might think, well, there must be lots of things that you could measure, and you're right. So, for example, we've talked about tau and TDP, those proteins that do build up in frontotemporal dementia. And really, that is one potential thing people have been looking at. The next thing is looking at, well, is there a marker that shows that brain cells are being lost quicker than they should? So you mentioned that the scan might not show something, but actually can you tell in the fluid that the brain cells are being lost faster than they should? And could you perhaps tell that the connections between nerve cells that communicate are breaking down? We know that there are little recycling systems called lysosomes inside the cell that normally clear up the clutter and the rubbish and then get rid of it as the cell goes about its daily business. There is growing evidence that those systems have broken down, and perhaps that's why the proteins build up. They're not being recycled and cleared away. And something that I'm interested in particular is, could there be problems with what we call inflammation in the brain? So inflammation means that perhaps if you get an infection or something else in the body, normally the immune system would attack it and get rid of it. There is growing evidence that perhaps in some cases of FTD that might be not working properly. So perhaps the inflammation carries on getting rid of things, and that could be harming the nerve cells early on. And that's what I'm looking into in my PhD. So the type of markers we hope to look into will not only aid clarification of is this FTD or not, but perhaps what protein is underlying it. And then over time, perhaps something that could be used to predict, well, when is the disease starting in those who carry those gene mutations? Or how fast is the disease changing in those who have disease already? And obviously the Holy Grail is to really look for things that can treat this disease and can be used to measure response to treatment over time in clinical trials in the future. Finally, I'm just going to talk about one marker that is promising in FTD, because it can be a bit bleak. You think, oh, there's nothing coming through, there's no treatments. Well, actually, there are things happening all the time in our research that show promise for this condition. So neurofilament is a name for a protein that is basically part of the nerve cell. And it's got three parts, a heavy, medium and light chain, and particularly people have looked at the light part of this protein. And we know that in other conditions that affect brain cells, this protein goes up in the spinal fluid and in the blood, because as nerve cells perish, this neurofilament is lost and it floats into the fluid. So what does this protein do in FTD when we know brain cells are being lost? Well, there's been two research papers looking at this specifically in FTD, and both of these papers have used samples that we've collected through a study that John leads, and there's different sites across Europe and Canada. So there's 26 different centres across Europe and Canada, and UCL is one of them. That's called GEMFI. And I'm just going to talk to you about that. So this particular study looked at 71 people who didn't have dementia and were healthy otherwise, who are a similar age to 101 people who had FTD, and then 62 people who had the gene mutation or were at risk of developing FTD but were well, so they were younger people usually. And they looked at this protein level in the spinal fluid. So all these people had lumbar punctures, they collected the fluid and then they looked at it in the laboratory. Now I'm just going to explain this graph. If you look at the graph, along the bottom of the graph are the three different groups. So the far left is the healthy people without dementia. The middle is the people who carry the gene but don't yet have dementia, and the people on the right are the people with FTD now. So you can see that all these little dots are the individual people. So you can see on the far right that actually the people with FTD have much higher levels of this protein than the people who don't have the disease or the people who are yet to develop it. And really the levels were far higher, they were 8 times higher. And obviously, individually, people have different levels within themselves, but overall, the average level was higher. Now, we're interested in markers to tell how quickly the disease is going to change or how aggressive the disease is. And in fact, this study looked at brain scans over time and how fast the brain was shrinking. And in fact, the people who had a higher level of this protein had faster brain shrinkage over time, suggesting if you have a higher level, you got slightly more intense disease. They also looked at how long people lived for. So on the right-hand graph, the people in the blue line had the lowest level of the protein, the green had the medium, and the red had the highest, the orange had the highest. And the graph basically shows over time what the chances of surviving are. And the people at the blue at the top had much higher survival rates than the people in the orange group. So perhaps this could be used in future to predict how long people might be able to live, but this is still on a research basis. This is a study that John Rohrer led at UCL, looking at the same protein but just in a different group of patients. So we had 67 patients with FTD and 7 patients with a condition that overlaps with that called logopenic aphasia, which mostly is due to Alzheimer's disease rather than FTD proteins. And along the bottom are the different clinical types. So we've got behavioural type, people who have frontotemporal dementia and motor neuron disease, people who have different types of language FTD, and people on the right-hand side are healthy individuals without any. And you can see here that obviously it differs between the clinical types, but also overall people with FTD also had higher levels of neurofilament in their fluid than controls. And the key thing about this study that was different from the previous one is that these were in the blood. So actually now we're moving forward. So you think, well, no, I don't really want to have a lumbar puncture every year to monitor my neurofilament. Well, now potentially the blood could be used as a sensitive marker for this. So this is really promising, and this is one of the most promising markers we have in FTD at the moment. Again, the blood levels of this protein correlated with how fast the frontal lobe of the brain shrunk. So on the bottom, you can see that from 0 to 8% brain shrinkage of the total volume per year, the people who had more shrinkage had higher levels on average. So summary of the neurofilament data. We can now measure this protein in the blood and the cerebrospinal fluid from people with FTD and other conditions. And they may reflect the intensity or how fast the disease is potentially going to change, and could be used to predict perhaps that and survival and potentially used as clinical trial data in the future. We know that this preliminary studies show that there might be different levels between different clinical types of FTD and also people with different gene mutations, but we need to explore that. And at the moment, we're not offering this as a clinical test, it's just on the basis of research. I'm just going to finish on some promising data from multiple sclerosis. So these are people who had multiple sclerosis on the far left, and then they received treatment for multiple sclerosis, and you can see how the levels of neurofilament came down, suggesting that actually the nerve cell loss had lessened with the treatment. So this could be used as a marker in trials of future treatments for FTD as well. So that's me at the top left. These are other parts of the team at UCL. So Misha in the middle is working on proteins related to the synaptic connections, the connections between nerve cells in the spinal fluid. Rochelle is going to be starting in August looking at TDP43, one of the proteins, and whether we can detect that in the fluid. Martha is looking at different forms of tau in the fluid. And Carolyn is looking at other peptides released by different parts of the brain involved in things like appetite and behaviour. So all of us are working, led by John, to further research in this field, and the hope is that we will find a marker that can be very helpful. So we've covered a bit about research into dementia, why it's difficult to study FTD. I've gone through how we did a lumbar puncture and why we use lumbar puncture to diagnose and do research into this. And I don't know if we've got any time for questions. Thank you very much for listening.